Well, good morning. I'm John Perlin, and I thank you all for being here today on working with the National Academy of Medicine on this tremendously important issue. I think Gary Mendel really poignantly reminded us that this opioid use epidemic is not an abstraction. It's real people, real individuals, real families, real tragedies, real loss of potential. While we heard the number of individuals who succumb every year to opioids specifically, approximately 72,000 a year. Since we began our work in earnest, 54,000 additional individuals have succumbed over those 9 months. But I don't think that has the same poignancy as hearing the story of the individual, the lost potential, the trauma, the tragedy. And while we heard Gary's story, I would be incredibly surprised if there were anybody in this room, perhaps not as tragically, but who hasn't in some way been touched directly or indirectly by the challenge of opioids or other substances of abuse, or the discontinuities in care that are really so exacerbated by the stigma and structural and social challenges. And the inadequacies in the fundamental research and the science and the availability of evidence, and the discontinuities in terms of putting all of that into practice. Fundamentally, this is why I think this program that the National Academies are putting together is so tremendously important. I can't think of another forum that has that same convening capacity to bring together multi-sectors, multi-skills, and really individuals with exceptional capacity to join forces to make a real difference here. And Gary, thank you for being here. Thank you for that inspiration. And I hope that the work you'll hear in these report outs, which is really the subject of our next hour and 45 minutes, begins to get at the sort of things that you hope to inspire by sharing the story that you shared with us. So this session is really the crux of today's public meetings, and we're going to hear from each of the working group co-leads about the missions, objectives, and anticipated outputs of their groups, which have been meeting by phone in earnest since the end of November to develop these plans. So the working groups will be joined by external reactors who will, following the working group presentations, offer guiding thoughts and considerations and challenging questions to inform the working group's strategy and our planning going forward. The presentations and reactions will start, and these are the 4 domains that Admiral Giroir introduced: health professional education and training working group, followed by the opioid prescribing guidelines and evidence standards. The 3rd presentation will be prevention, treatment, and recovery services, and the final, research data and metrics needs. Now, none of this mentions stigma overtly, but I can assure you that from the conversations in each of these groups, that has been a part of the discussion, and one that deserves important attention here. Once all the working group presentations are complete, we'll hear a final and summary reaction from Richard Frank of Harvard Medical School. And after this, we'll move into our public comment, question, and answer period, where we'll invite attendees here in this room and online to ask questions and make any brief comments. With that, allow me to introduce the co-leads of the first group, the Health Professional Education and Training Working Group, where to my immediate right is Dr. Kathy Chappell, Senior Vice President of the Accreditation, Certification, and Measurement, and Institute for Credentialing Research at the American Nurses Credentialing Center. We're privileged to have Eric Holcomb, who works with Dr. Tom Naska, President and CEO of the Accreditation Council for Graduate Medical Education. And following Kathy and Eric's presentation, we'll hear from their invited reactors, Dr. Richard Hawkins, President and CEO of the American Board of Medical Specialties, and Dr. Ronald Severo, President and Associate Director for Remote Campus Education in the Department of Medicine's graduate programs in the Health Professions Education program at the Uniformed Services University. Everyone's full biography and contact is in your materials, and let me turn now to invite Kathy and Eric to begin. Thank you.
Thank you. So on behalf of the Education and Training Work Group, here are our co-leads. I'm sorry? Oh, it's also right here. Can you all see?
No, they don't have to see. Can you see through us? Yes.
Yeah.
We're going to step
We'll shift over a little bit. It's in your book too. This is the mission of the Education and Training Work Group, and I wanted to call out a few words here that I think are critically important for the discussion. We did talk about a harmonized approach, and I think that to us meant that we were collaborating, but we didn't have to have a one-size-fit-all for all professions. We needed to make sure that we were complementary and not competing. We also specifically called out an interprofessional approach, and I think not only does our committee reflect multiple professions, but it also gives us the opportunity to learn from, with, and about each other. And we wanted to make sure we had a patient and family-centered focus, and I think that was highlighted in the early presentation. I'm going to go over briefly the 5 objectives that we have and the actions that we're going to take related to achieving each of those objectives. So we are looking at concurrently, Objective 1 and 2 we're doing at the same time. Initially, we're looking at what are professional practice gaps that are in healthcare that currently exist in relation to pain management and substance use disorders. We did specifically call out 6 professions, and that's not to say that those are the only 6 professions that care for patients, but within the 2-year scope that we had, we thought that that was an achievable goal. So we're looking at physicians, PAs, registered nurses, and advanced practice registered nurses, dentists, and pharmacists. And we're doing a review of the existing literature to find out where those gaps are that have been published, but we also want to triangulate that with listening tours. So we want to get a sense of the lived experience of both the clinician, but also the patient and family who are in this space. For Objective 2, and again, this is concurrent with Objective 1, we're taking a snapshot at the landscape, and we're looking at the regulatory landscape or the standards that are set both for individuals and for organizations or programs. So we're looking at accreditation standards, certification standards, and licensing standards that reflect pain management and substance use disorders. And we want to see what professions are doing well or where they're not doing well or where there are gaps. And do those differences make sense? There may be standards in place for nursing that are appropriate for nursing, but they may be different for medicine, and that's okay. But there may be areas where we want greater alignment, and this will give us kind of a snapshot of our landscape in order to compare and contrast and make some decisions. For our third objective, we're looking at creating a resource hub of evidence-informed tools that exist, and they exist in a lot of different places. So this may be curating tools into one location, or also creating paths by which learners, faculty can access those resources and find them as appropriate. And then developing a summary or white paper with that information. For Objective 4, we're really looking for a commitment from a variety of stakeholders, and I think, again, this reflected the earlier presentation, that we need people to commit to making changes. And then in our Objective 5, we're looking at how are we going to evaluate the impact of that commitment. And I think I'm going to turn over to Eric, but with one last thought. One of the parts of the discussion that came up yesterday, it's not only caring for the patient and family, but also a component of caring for the caregiver, because this is really difficult work for all of us who are involved in this space. And I think there's a component that we need to reflect in terms of how we make sure that we care for ourselves in addition to patients and families. So Eric.
Okay, I just want to add a few more comments, kind of building on our conversation from yesterday. One of the things that came up was the ability to potentially look at competencies across the professions and see which of those actually might be also harmonizable, if you will. There's just all things that all health providers should be able to do, such as identification of just somebody who may be at risk or having a substance use disorder may be one example of that. And so we talked a fair amount about that. The second was this tension between the standardization and kind of flexibility. Instead of treating that as an either or, looking at it as a both and really pulling, again, across these interprofessional teams, how can we look at that in a way where we might have some common shared mental models around this serious issue and bring that together. The third was to really think along the continuum that I think we heard earlier today how important workforce is, but that's also those who are beginning this journey to be a health professional, but also how do we address the current workforce who may not have received this type of training during their own earlier education. And so I think that's going to be in a really important conversation, is how do we look at workforce across that continuum. And then the last, really looking at a lot of the organization as kind of connectors. There is a fair amount of good stuff that's out there. Obviously, there are gaps, but I think we heard really wonderfully today from Gary that there is stuff out there where we do have some evidence, and how do we get that more out into the communities? How do we prepare people better to do that? And so this is an area where both the regulatory organizations, but also all the various societies involved may be able to collaborate to really advance some of that implementation. And we talked a fair amount about that implementation challenge yesterday. So I'll stop there and turn it over to Rich and Ron.
Thank you. And first, thanks to the Academy and the Collaborative for addressing the national crisis on pain management and addiction. Can you hear me okay? Your multifaceted approach to taking this on is to be commended. It makes sense to broadly consider education and training, clinical evidence and practice guidelines, prevention and recovery, and data sharing and research as parts of the solution. Your intention to act broadly across the health professions and the continuum of education and practice makes good sense. As well, a coordinated interprofessional patient and family-centered approach is essential. I would add to that consideration of community-based or community-oriented approaches. Upstream interventions may be among the more effective and efficient interventions for complex social problems. In terms of the objectives defined by the Health Professions Education and Training Work Group, I'll focus on the first two as requested. As planned by the working group in Objective 1, it will be important to identify practice gaps for health professionals in pain management and caring for patients with substance abuse disorders. Beginning with a thorough and clearly articulated literature review, as well as reaching out to selected organizations and networks within the professions to determine what gaps have been identified, is a good start. It seems one essential prerequisite would be for the professions to come to some agreement as to what constitutes effective practice in this area, so that the gaps between observed and expected performance can be more consistently identified. Also, I would not assume that there are effective measures in all the areas that are within pain management and addiction management. I made these comments, and actually some of the Academy's work may be involved in stimulating or facilitating the development of appropriate measures. I wrote these comments before hearing Shatterproof's presentation, and it seems like you're getting us off to a really good start in that regard, so thank you. In terms of Objective 2, it will be helpful and likely very informative to analyze the various regulatory requirements and standards. Accreditation, licensure, and certification are important drivers of learning and practice at the individual level and at the program level. Ensuring appropriate requirements for educational programs is essential in facilitating the acquisition of the relevant knowledge and skills regarding pain and addiction management. However, I would look beyond just the educational content required by accreditors to the assessment content that's in our regulatory assessment processes. Learners in the health professions prioritize some of their learning based upon licensure and certification examinations, perhaps over what's involved in local program content. This suggests that we could ensure learners acquire key knowledge and skills, not just by requiring it to be addressed in their educational programs, but by requiring that it be included in their assessment content in the regulatory process. I also would point out that licensure and certification exams programs can provide a source of information linking Objectives 1 and 2 of the working group. For example, in medicine, licensure and certification assessments and continuing certification programs can help gather important data regarding the state of learner and practitioner knowledge, skills, and quality of care with regard to pain and addiction management. For example, within the ABMS boards community, we just brought content experts from 10 boards together to write test items on addiction and pain management with the focus on opioid prescribing, and are about to share those across all the boards. Soon we'll have data on a national sample of physicians in terms of what the gaps are in their knowledge with regard to opioid prescribing. There will likely be more consistent and structured methods and content in the undergraduate and graduate space rather than as compared to the practice environment. Impacting change in the practice environment will require significantly more work. A collaboration among regulatory agencies, societies, academic health centers, and health systems will be challenging, but necessary to ensure learning and practice objectives are achieved. This will be an important role for the Academy to take on as well as the collaborative. Adding to the challenge, further differentiation of practice focus, I think Kathy, you mentioned this, may dictate varying requirements and approaches across scopes of practice. Very broad requirements across specialists with different practice foci may actually distract practitioners from focusing on knowledge and skills that are most relevant to their patient needs. We'll need to be focused, judicious, and deliberate in addiction and in developing, ensuring acquisition of the relevant knowledge, skills, and attitudes in addiction and pain management for a diverse group of practitioners. This will be a challenge. Lastly, I'd like to comment on the final activity planned for each objective. White papers and webinars will be useful in facilitating wide dissemination of the collaborative's findings and recommendations. However, my colleague on this panel has published on the value or lack thereof of enduring materials alone for influencing behavioral change and impacting patient outcomes. Interventions that are repetitive, continuous, and require engagement, active engagement, are more likely to lead to behavioral change and more likely to influence implementation of your recommendations. I saw that Objective 4 for the working group involved engagement of all stakeholders. I would hope that such engagement follows those evidence-based learning principles that impact behavioral change in physicians. Thank you again for the opportunity to comment on the collaborative's plans. This is important work, and it's critical that you succeed. Thank you.
Thanks, Rich. And thanks to the Academy for the invitation to speak and be part of this really important project. Obviously, education is going to have to be a central pillar of any kind of response to this crisis. I think there is a lot to like about what you've already developed. The patient and family-centered focus, the notion of it's going to be across a continuum, so lifelong professional development where everything is connected, and finally the whole approach, the interprofessional approach to education. I think these are essential parts of any education moving forward on this crisis. I want to make 3 points in my limited time. I want to talk about a potential curriculum or competency framework. I'd like to talk, secondly, about the educational strategies that you all are going to be dealing with, and finally, maybe make a pitch for how to enable success on the education and training side of this. So, if you look at the 5 objectives, and you look at objective 1, 3, and 5, this is essentially a curriculum development project. And as necessary, it's going to start out with a needs assessment of practice gaps. That's absolutely essential. We're not going to solve anything until we know what the problem is. Secondly, objective 3 are the educational strategies that are obviously going to flow from that, and the focus on the evidence-informed is really important. I want to pick up on some of the points that Rich just made about what we actually know about evidence-based education. And finally, and appropriately, objective 5 will focus on, have we made a difference? Have these changes been adopted in practice? So, the one additional point I'd like to urge, or at least urge considering, is I think there's an opportunity to develop either some kind of competency or curriculum framework across these 6 professions, thinking about the core, like you do in undergraduate medical education or graduate medical education. There are core sets of knowledges and skills that people are going to share across the professions, and then you have electives that's highly differentiated by who the prescriber is and who's involved in the process. This is routine at the pre-licensure level. We haven't quite gotten there in the practice space of continuing professional development. I think Rich made some comments. We are moving in that direction. Why wouldn't you have a curriculum throughout the lifespan? We have it for the first 2 phases, and I think this project is an opportunity to move in that direction on this critically important topic. The second point has to do with the strategies and tools that you talked about, Kathy, and as the keynote speaker mentioned, the whole focus on the science of treatment and addiction and so on. And like there is a science there is also a science of education. And so we do have a lot of evidence across the health professions about what we need to do to be effective in the educational space across the lifespan. The Institute of Medicine published had convened the group and published a book in 2010 called Redesigning Systems of Continuing Education for the Health Professions. One of the chapters is the scientific basis of continuing education. And what we know about how to improve performance of providers and how do we make a positive impact on patient health outcomes. I've recently updated that a bit, so I want to just talk about 5 things we feel like we know about any kind of continuing professional development. First of all, number 1, there must be a needs assessment that's focused on the practice gaps. We have to know what the problem is. Number 2, we know that the more intense a program is, how long it is, how many exposures the providers have to this knowledge leads to greater uptake and performance change in patient health outcomes. Number 3, we need to involve active learning strategies. It has to be interactive. People shouldn't just be sitting there. They need to be engaged because engagement will lead to learning. Number 4, the education needs to be focused on outcomes that providers consider important. It has to make sense in the context of their practice. And 5, finally, there needs to be administrative support and alignment, policy alignment for any of these practice changes. So this is going to lead to my third point. I want to talk about this administrative support and policy incentives and how crucial that's going to be in this project, as it is in any education where you're trying to change practice or improve patient health outcomes. I feel like, given everyone that's on board for this project, objectives 1 and 2 are going to be successful. We're going to find the practice gaps. There's going to be a lot of evidence around how to provide this education to make a difference. As we think about objective 5, which is evaluating the impact, I'm less certain because, if you're just focusing on clinician education, that's only going to take us so far. So we need to improve clinician knowledge. We need to improve their skills. But what's going to make a difference ultimately is we're going to need the political will and the organizational alignment for these practice changes across education and healthcare providers. So I know you've got a big task in front of you with clinician education, but if possible, if there's any bandwidth, in addition to educating clinicians at the individual level, I would urge a consideration of the education of the leaders in the ecosystem, the CEOs, the COOs, the CFOs, the policymakers, and the payers, so we can enable this alignment of administrative support and policy incentives for the changes that clinicians want to make for their patients. And I think these 3 will allow us to make a difference in changing practice and patient health outcomes. Thank you.
Well, I know that you have 1,000 questions. We'll have time for Q&A at the end, but at this moment, please join me in thanking the presenters for a terrific set of comments. As someone who's been in education for a long time, I'm glad to know there is a dose response curve, so I thank you for that.